Welcome to our January 19th, 2023 Water Commission meeting. Madam Clerk, could you please do our roll call?
Yes. Chair Young,
Here.
Vice Chair Cooney,
Here.
Commissioner Snyder,
Here.
Commissioner Keller,
Here.
Commissioner Davis,
Here.
and Council Liaison Sneddon.
She said she would be a few minutes late. Okay, thank you. Mr. Hagmark, any changes to the agenda?
Chair Young, there are no changes to the agenda.
Okay, thank you. Public comment, if there's any member of the public that wishes to address the commission on any item not on the agenda, now's the time to do so. Do we have any speaker cards or anybody online that wishes to talk to us?
I see no hands raised, so no.
Okay, great, thank you. All right, consent items. Mr. Hagmark?
We just have here is the meeting minutes from the last meeting.
Move to approve. Second.
Okay,
Commissioner Davis,
Yes.
Commissioner Keller,
Yes.
Commissioner Snyder,
Yes.
Vice Chair Cooney,
Yes.
and Chair Young.
yes.
Public comment, Jeff.
Do we have any public comment on our consent agenda?
No public comment.
Great.
I'm asking about the general public comment, not item 3 or 4.
Okay. Oh, I did that.
Okay, I'm sorry.
Okay. That's what confused me.
I'm sorry.
All right, moving right along to item 6A, utilizing emerging wastewater surveillance testing for the advancement of public health. Mr. Hagmark.
My name's Amanda Flessy. I'm the wastewater manager, and I will be presenting this subject. So our presentation today is wastewater surveillance. When putting this together, we realized we have not really spoken to the commission about wastewater surveillance. So we wanted to take the opportunity to define wastewater surveillance. What is that in the community and the world, and what we do with it in our community since we've been testing it over this COVID period. And the use of our COVID-19 wastewater data, how we share that information and how they utilize it. And what are the future opportunities now that we're nearing the end of this pandemic? Wastewater surveillance. I'm just going to take the opportunity to kind of define what wastewater surveillance is as a science. This is a science of taking what is found in wastewater, so from the feces specimen, and understanding different types of things that could be in our health, whether it is viruses or medical items, just any kind to understand the population's level of health and the trending items of that. We often call this epidemiology. It's actually a term and a science term for it. Wastewater surveillance. So this was actually, we first heard of wastewater surveillance in the Netherlands in January of 2020. They started testing the wastewater for the SARS-CoV-2, the virus that causes COVID-19, and they actually started seeing it in January before anyone even tested positive for it. What people don't understand is they can really be infected with COVID-19 before any symptoms. Mostly it shows up in their feces when they start shedding it 7 or 10 days before they even get one sniffle or body ache or any kind of symptoms for COVID-19. This virus can only be detected in the feces because they start shedding it in their body. That gives, if we're on top of things, that gives the medical community probably a good indicator of what it will be the impact for the following week with the COVID-19 symptoms. So how does this work? Wastewater is collected in the collection system right before the treatment plant. Samples are sent to a specialized health lab that tests for this SARS testing. We don't test for this at our lab here at El Estero. the testing data can then be used for information for our medical community.
And the sampling is composite testing, right? So it's intervals that it's taking throughout the day.
Ours is composite. There are different types of ways to sample, but ours happens to be composite. So what it really can do in the community, and this is actually what Italy kind of did because they had a really bad outbreak. They started going into communities, really pinpointing communities to find out and testing the wastewater to see where that COVID-19 was hitting within the communities. We don't do that here. We test the wastewater system as it comes into our treatment, so we just know the city of Santa Barbara. We collect the sample, the composite sample, for one whole day. We prepare it, overnight it to a lab in Florida where it is then analyzed for the COVID-19 virus. So what do we do here at Santa Barbara? Just to give you kind of a brief history of our COVID-19 testing. City of Santa Barbara, we started this program with BioBot Analytics back in March of 2020. They reached out to us right at the beginning of the pandemic, and they had some grants that allowed us the first 3 months free testing, and it was every 2 weeks, and it was free testing. However, we weren't really confident in the results and the lab testing. There was no quality control when we asked about the testing methods. They weren't really forthcoming with how they did the testing methods. It's proprietary information. So because we could not really stand behind their testing methods, we felt, why don't we go and see if there's other labs? Because after the 3 months, their price increased quite a bit from free to $300, which was basically $600 a week, because we were testing twice a week. So we began searching for other labs, and in 2020 of June, we found Source Molecular. They offered the same kind of testing. They shared with us their testing methods. It was all in the same kind of lab and kind of regulations that we kind of adhere to. So what we did is we started to fund the testing at $215 plus shipping and samples, so it's actually a little bit more, plus our time to collect these samples and prepare it. And so we prepared the sample, shipped it off to Florida, and then we would receive the results back in about a week. What that means is we would lose our time in between of that nice week time before the results, before the health community would see what we saw in our testing. So what we did is we tracked the reported cases in the community, and I'll show you what we did. So we graphed it. So we pulled the results from the county of what they put out of how many people were infected or tested positive. So we had to extrapolate the city's population because we are just testing just for the city of Santa Barbara. And so we kind of graphed it to the best of our ability. We are not epidemiologists, so we did not have really the expertise to understand how this related to the actual R1s and R2s in the COVID SARS data. So we did what we could. It's not a true analysis of the data, but it did show that we were on the same trends as who was testing positive within the community.
Can I just ask you a question, like, what does that mean? In other words, if there was a true analysis done by people competent to run the statistics, how would the presentation of this data be different?
We will get that get to that later on in the presentation when we bring in our experts and they help us run the data now, a true analysis, and they can tell us what that means. And here we go, nice segue. So our Santa Barbara Community Health Wastewater Collaborative team. I want to introduce, so this is our collaborative team. We have with us from Cottage Health, Dr. Lynn Fitzgibbons. She's our infectious disease physician. She helps us with the analysis of that data. We've also been working with UCSB, Dr. Trish Holden. She's an epidemiologist research professor there, and so we've been working with her on the research of this. And then Legacy Works Group, Mr. Carl Palmer is here. They actually help us communicate that data when it's interpreted by our health officials. And this is part of our team. Wastewater surveillance dashboard. This is what it looks like when actual analysts analyze our data and put it in coordination with who has tested positive. So the data is normalized using common virus shed by humans, and then they report out both strains, the N1 and N2. Here's our current challenges with us sampling. We only sample once a week. So it's a good indicator, it's a good trend indicator, but if you need it for more to make health decisions, you'd probably need additional sampling. Another big one is our laboratories in Florida, and what we have dealt with this year with a lot of hurricanes, a lot of weather events, the shipping industry, it has really impacted those results, and sometimes those results are null and void because by the time the sample gets to Florida, it's no longer viable. We must wait 3 or 4 days for that shipping time to go back and forth and data is analyzed. So, and also the data is only being shared locally here with us, not currently being compared to any state or federal data. Funding the data analysis. $20,000 was received in local gifts, and I believe that was more from the Legacy Works. If Carl, you want to speak to this slide. Sure. Yep. I believe this is your slide.
Yeah, thanks, Amanda, very much. Yeah, great to be here today. Thanks for inviting Lynn and myself, Dr. Fitzgibbons and myself to join you. Want to commend the city and the Water Commission, the water resources team here. They've done a fantastic job through the pandemic. Really stepped up when there was a clear need for additional data and met a need that no one else in the community was meeting. No one else ran a water treatment facility either, but you all were in a position to do it, and you took initiative to do it, and you're really to be commended. It was a great service to the community, and Dr. Fitzgibbons can speak to that better than I can. But we were invited by the team to engage and to be of help expanding that for a period of time when early in 2021, there was a new surge coming, and we weren't sure what that was going to look like. There was quite a bit of concern in the community. And we, together with Dr. Fitzgibbons, Dr. Holden, and other members of our collaboration, successfully went to a couple of philanthropists and raised some dollars to expand testing at that point in time. Was that 2022 or 2021?
It was
end of 2021, yeah. Thanks. Yeah, our team built the dashboard that Amanda showed you the chart from that you may have seen to present the data from the collaboration and make it available on a real-time basis. As soon as the sample came in, we would run the analysis. We would follow a methodology that Dr. Holden and her colleagues and Dr. Fitzgibbons approved to make sure that it was normalized so that we could report it accurately. And then We also, as a team, worked together to uncover those data anomalies when we were getting sample data back that didn't seem like it was accurate, and developed a protocol for validating each sample along the way. That allowed us to put the information out in the community in a way that folks like Dr. Fitzgibbons could use in real time, and the Public Health Department could use in real time to make decisions. So it's been really impactful and helpful, and it's led to an interest amongst all the partners to expand this work significantly, building on the beginning here at El Estero. We did put in for additional funds with Representative Carvajal's office this past year. The UCSB led the application process to build a local wastewater treatment, wastewater surveillance laboratory, where at UCSB, the Bren School offered up space. Dean Gaines there was very supportive, and the intention still is to do that, although we did not receive that federal funding at that time. We intend to go back to Representative Carvajal's team and are seeking out additional opportunities for funding so that we can address some of the issues that Amanda ably raised earlier about that analysis and what we were able to do with it. I think Dr. Fitzgibbons is going to speak to the potential impact of that and the uses that sort of a facility could be put to.
What would be the cost of that lab?
You know, that application was for several $1 million, actually. It's pretty significant. And I forget the exact number. $2 million, yeah. That's exclusive of the operation of the lab, which then we would be looking to build a business model around in terms of getting multiple jurisdictions to contribute resources to that, including public health, but other agencies throughout the community, to contribute to the maintenance and upkeep of that, so that we would be able to regularly sample from throughout the county and potentially likely the region, the Tri-County region, to get visibility into all sorts of critical public health matters. Should I hit? Yeah, great.
Thanks, Carl.
You bet, Lynn.
Thanks for the chance to speak to you. Just to, again, open and echo the gratitude, I think, to the El Estero team. Our community is safer because of wastewater testing, period. We as a nation, we as a world are actually far safer today than we were on February 25th of 2020, unequivocally. And the reason for that is, I don't know if you remember that date, but that was the date that we found out that a woman from Vacaville had COVID. She had no reason to have COVID. It was absolutely a turning point in this entire thing. Today, you may have heard there's Marburg virus in Equatorial Guinea. There's none in our community, as far as we know. No one is testing for Marburg virus in our community, nor should they, from an infectious disease perspective today. I'm not very worried about that. I'm not here to panic anybody. But my point is, February 25th, 2020, we weren't testing for COVID. In fact, for the following 2 months, comments on kind of the funding and infrastructure around the CDC's testing program for the year or two before that aside, we actually didn't have testing capacity in our community. And it took a couple of months before we had, as infectious disease physicians, easier access to even test the people that we were worried about. As Amanda mentioned, I'm an infectious disease doc. I work at Cottage. I also actually am the infectious disease physician for the Santa Barbara County Public Health Department, formerly deputy health officer. Not speaking today as a health official, though, just speaking today as an ID doc and someone from the community. It is absolutely a certainty that because we, the global we, have the ability to monitor pathogens in wastewater in 2023, that we're safer. As we start to worry about poliovirus, as we start to worry about the next Marburg, I mean, I don't know what the worry in 6 months and 6 years is going to be, but the COVID-19 pandemic has propelled us forward with the ability to look for these emerging diseases in our wastewater on a population level that, as Amanda mentioned, is helpful when we're thinking about diseases that may cause a lead-in of asymptomatic periods. She mentioned and articulated very well that I may well have a disease like COVID, and there's a period of time where I'm incubating. I could be infectious, but I don't know I'm infectious. And even if I have access to testing, I don't yet know that I'm a threat to anybody else. The beauty about wastewater testing is that it really is a very equitable approach to public health, to population health. It's in its infancy, and I'm not here in any way to comment on the money around this, the policy around this. I'm just here as an ID person to tell you the power of this new population level approach to infectious disease monitoring. And again, very much making lemonade out of lemons. COVID-19 has moved us forward so quickly in so many ways. And I think that the wastewater surveillance opportunities may be, from my perspective, from our population's health perspective, the most important. Again, just credit where credit's due. The Elistero team was ahead of all of the infectious disease folks in the community on this. They were doing this before we were thinking to do it, quite frankly, and they were doing it well. And so, just a quick thank you. The way that we traditionally measure infectious diseases, as you all know, are case rates, hospitalizations, and deaths. So we're looking at case rates, which are, of course, reliant on the fact that everyone who may have the disease is getting access to testing, right? I mean, this is you all, I know, are very data-driven, and I think that following case rates is really helpful, but of course it's marred by problems such as access to testing. As I mentioned, from an ID perspective, unfortunately, in those first couple of months, I didn't have universal access to testing for anyone who was suspected. We, of course, had some testing bias, if you remember, in those few months. The data's been so heterogeneous and difficult to follow. Apples to oranges, kind of seemingly month to month. But if you remember, for the first few months, we were only allowed to test people who were really severely ill. We didn't, as my kid did this weekend, test herself for COVID with a little home swab. We, of course, were much more judicious with our testing, and that impacted case rates. As testing access has changed, so too have, of course, case rates, and we've got to take every one of those surges with a grain of salt. Hospitalizations are a bit more, perhaps, objective. And deaths, I would say, are moderately objective, but even those are fraught with challenges. As someone who, it's not a topic for today, but someone who has cared for hundreds and hundreds, if not over 1,000, local patients with severe COVID in our community. At our peak, we had 105 patients at Cottage Hospital, and we did have absolutely certain deaths from COVID. We also had patients that had other problems and had COVID. And as I consider myself an experienced infectious disease physician, it was sometimes hard to figure out the contribution of COVID to perhaps a death. And so just a quick, perhaps aside to point out that even deaths, as has certainly been talked about in the media, even deaths is seemingly a hard data point. It's really hard to track a pandemic just looking at death certificates. And so then the question is, what is the right solution? Amanda, can you go to the next slide? And so I think I point this slide up from the CDC just for those of you who really do enjoy the data, as I do, and the good question that came from Chair Young earlier. How do we choose to analyze the data? This is not Santa Barbara City data, this is national data. And this is looking at the Omicron era, so thinking really from, if everyone remembers, my last few holidays have been defined by the variant of interest. Thanksgiving, you guys don't? Yeah, thank you. You guys don't do that? What I ask you to look at here is the fact that in my estimation, there has not been a very significant change in how deadly each one of these Omicron variants has been. Perhaps subtleties, but it's not shifted significantly. What has shifted has been our population's level of immunity based on natural infection and vaccination, but what's also shifted has been how frequently our public is testing in a way that gets reported to public health departments. Okay? Now, I did say in the last slide to remind you that hospitalizations are probably one of the more objective ways to follow surges because people being admitted to the hospital with severe disease are people being admitted to the hospital with severe disease, period. I mean, it's a pretty straightforward thing to follow. And so here you see, if you follow the orange line, this is, and the y-axis is on the right-hand side. These are new hospital admissions over the last couple of years, or last 18 months. And what you see is underneath is the case rates, so the reported case rates. And I just gave you kind of my offering, my opinion that the proportion of people that get severe disease in any one of these months with the Omicron variants hasn't actually shifted that much. I mean, thankfully, we are seeing far less in the way of severe disease, but what we've actually done is capture far fewer of the cases, because the only cases that are showing up on this graph, this is again not wastewater, this is case rates, the only data that's showing up on this graph are the people that are going to a doctor to get tested. Had my daughter tested positive this weekend on our home test, I certainly would have followed public health and school board or school district rules, kept her home, but she never would have shown up on this graph. And so the point is just that as this pandemic has shifted in a very positive way, we're no longer able to look to the data that we looked at perhaps in the fall of 2020, the winter of 2020-21. And so we have to look now at how can we understand how pandemics are moving through our community, and wastewater is, again, arguably the most objective way to follow them. Next slide. And so I think I just really want to emphasize the point that I think we've perhaps just all, I'm grateful for the nodding. I was a high school teacher at Santa Barbara High School in a past life, and I'm grateful for for the nods. But I think everyone very much understands that from an ID and pop health kind of perspective, really wastewater is the best solution to understand how much of a disease is in the community. But also, again, I opened with the fairly dramatic example of Marburg. Just the idea that in addition to understanding what's going on with a pandemic that we know we're following, or even an epidemic, or even something that we're used to following, RSV, influenza, norovirus. Norovirus as an example. We actually can do that in the wastewater. In addition to that, though, if there is a new, perhaps really concerning emerging disease across the world, and we're not testing for it ubiquitously, and our clinicians maybe appropriately aren't looking for it, if we have a way to surveil for it, it means that we have that first indicator that perhaps it's starting to show up. And to inform our public health officials, who are my wise colleagues, again, I'm no longer a public health official, but my wise colleagues who really have guided our community so well through this pandemic, to alert them as fast as possible that there's something perhaps to worry about or to pay attention to or to look for. And so I'll just finish with one example. So this is not City of Santa Barbara data. This is actually the Lompoc Regional Wastewater Group. They did register with a national group. It's called Wastewater Scan. And what this group does, this is just, I mean, this may be interesting actually for perhaps the commissioners to look at offline, just to look for interest at what this group is monitoring. But this is actually real data from the last 4 months, last three or 4 months of the Lompoc catchment area, what the concentration of SARS-CoV-2, the virus causing COVID-19 disease, has done. As you see, it's trending down. On the right there, as I think everyone knows that we've been following closely in the hospital and at the public health department, influenza had an early big peak and then seems to have disappeared. Quite interesting this year. RSV caused a lot of disease, particularly in children, as you can see, around the November, December, and into January time, but now has kind of stabilized a little lower. Human metapneumovirus, another virus, and actually I didn't capture it on here, but I regret that because the slides were due on Friday. But over the weekend, a lot of interest in norovirus. If you are interested, they're actually also tracking norovirus. So you can actually follow how much norovirus there is. And as someone who worked this weekend in the hospital and saw patients from around our county, norovirus is with us. I think just more and more examples of, I think, where the future is going with regards to these infections.
Future opportunities in testing and collaboration. I think that is obvious. That's the way that we go now. However, we have looked at state and national wastewater surveillance programs. We feel that is where the data needs to be, and not really localized, but looking at what's going on in our state and how is that progressing. So the city has begun exploring state and national wastewater surveillance programs. CDPH, CalSU users, that one we looked into. Only problem with that, their funding goes away this summer. So there's not much there. They pointed us to Wastewater Scan, where they have more funding, where we could possibly keep testing for the next year. How their funding ends up expiring in 24 of the summer. So, but those results are submitted to the CDC, as Dr. Fitzgibbon just demonstrated. Lompoc went ahead and got involved in this wastewater scan, and they are testing more than just COVID-19. So we can become a part of that larger database. So the state and national programs, just want to show you the difference between the two. The sample is still collected by the wastewater staff. However, it is going to be increased to 3 times a week. You get better data that way. The cost the cost of testing and shipping is covered by the program. The testing lab is in California. It's not shipped out to another state, so that we will get our results faster. 48 to 72 hours instead of 3 to 4 days. So we get them a little bit quicker. Right now, we're still collecting the wastewater. We're only once a week. We do incur that testing and shipping funds. The testing lab is in Florida, so we are at risk for any kind of shipping delays. So now we would like to have a great discussion and get some feedback from our Water Commission and any other questions any might have.
Any questions from my colleagues? Okay. We go, Councilmember Snedden, and then Arturo? Okay.
Thank you. That was such a fantastic presentation, and especially because we've been following this from the beginning when we got hints of that, oh, maybe it can be seen in the wastewater, and then when you just mentioning norovirus. And the question I have is about, well, first it seems clear that we need to be doing it more regionally so that we really know what's happening. But in the communication, I get this question a lot, like, so, okay, you see it in the wastewater, then what? So what is the action that public health or that we as a community can take with every new strain or trend?
Great question. May I take this one? That I think was part of the story that Carl alluded to that I'd love to perhaps emphasize a bit more, which is the way that this is done best is with partnerships and collaboration. And behind the scene, again, credit where credit's due, Carl, without ever taking credit himself and his group, has a remarkable ability to make sure that people who have aligned interests connect and move forward in often really, really powerful and constructive public-private partnerships. That's really what LegacyWorks did here. LegacyWorks basically said we have, just again, perhaps this ought to be emphasized too. Professor Trish Holden at UC Santa Barbara is actually really a national, if not kind of global expert. She was an author on the Sentinel paper that talked about COVID-19 and wastewater that gave guidance to folks around the world. We have in our community a just remarkable expert. And so Carl, I think recognizing Trish was here, that I have a lot of interest in infectious diseases, and that, again, this LSDRO team had the foresight to just start doing this early on. I think that synthesis it's what has been successful here locally. I think that going forward, the way that this works best, and this is, I think, perhaps your point, is there has to be collaboration between the clinicians, the epidemiologists, and the wastewater analysts. And I think that you have a huge, in our community, have a huge group of infectious disease passionate physicians and clinicians who are eager and chomping at the bit to get this data. Again, our public health officials have been incredibly supportive. Health Officer Ansberg, of course. And I think that part of a solution going forward has to certainly be, how does this get funded? With what frequency is the data being followed? But then really married to that is who is going to be interpreting the data for the sake of the public, and also, and I say that sincerely because I think that's a different question than for the sake of the public health officials. And those are two subtly different questions, but importantly different questions. So I think all I would say is it's a great question. I think it has to be asked as decisions are made going forward about whatever process was to be put in place long term. Sure.
Go ahead.
I think this is fantastic. I mean, the commission has been very supportive of this from the beginning when we started with this, and I'm very happy to see that public health now has really used this information, because for a while we were like, is this information going to be used for something? And I think that was a big concern. Where is this information going? I'm happy also to see that, there are other opportunities, because I knew that we were having some trouble with shipping the samples far away. So I think it makes sense to, work with someone that's close by. I think I would be very, very supportive. And in terms of the funding and support, I think, of course, for now, it's going to be something that they cover. But I think there's Santa Barbara County Public Health should definitely be involved in looking for funding opportunities for the whole county. They're in charge of public health at the larger scale, in collaboration with our local hospitals and all that. But that should be one of the main, and then also working with public officials at the state and at the federal level. So that I think we should be making that case. In addition, separately, of course, the research is needed. So I definitely think that, we should keep helping Dr. Holland get her research funding. But I think the important thing is the monitoring is really, really important. I would be very supportive for anything that needs to be done in that way.
Cora.
Thanks for the presentations. I had a question about this comparison of kind of state and national programs and what we're doing now, and also the proposal to potentially stand up a lab at UCSB. What are the kind of pros and cons across those different options? Are they all being considered, or is there one that's strongly preferred right now?
Take a look together. I can start. I'm a big believer in systems and not doing things in silos. I think that as much as we can, I think being somewhat uniform, making sure that what we're doing here locally has integration with what we're doing regionally, and then again integration with the state, of course, and also at the federal level. I think having said that, there are always going to be important opportunities and nuances for what is happening locally. And I think that to be optimally reactive to anything that's changing. Again, in our lifetime, I very sincerely hope that we never have another February, March of 2020. I really do hope that. But I think that if or when that were to happen again, leaning on local expertise is absolutely pivotal and critical. And so I think that my answer as a clinician is, we can't do something different than everybody else is doing. I think being integrated in that way is really important. But at the same time, I think making sure that we have experts locally who are interpreting the data as it really applies to our community and our health officials, really making decisions based on it, tailoring it to our needs is a really important part too.
Yeah, I very much concur with Dr. Fitzgibbons on that. I think we want to make sure we integrate across those broader efforts. And at the same time, I think there's no substitute for local capacity. We have our own unique needs and challenges, and we didn't speak about it today, but Dr. Fitzgibbons and quite a few partners, Dr. Arias out at UCSB, who's now no longer at UCSB, but her lab and other labs stood up a world-class effort to track variants in our community at a time when that was very difficult to do. And we were able, thanks to that effort and real-time genetic sequencing that UCSB partners were able to do at the time, to track which variants we were facing at a time when that was incredibly meaningful information for public health policy, for staffing decisions at hospitals, for treatment decisions, which patients got which medicines at which times, how you allocated really scarce resources. So that's a beautiful story of something that happened here in our community because of the kind of expertise and resources that we have, the people who are here who could do amazing things that only a handful of people in the world were able to do at the time. And I see this potential to start a regional wastewater surveillance lab here in that same light, because we can use wastewater surveillance to track infectious diseases. We can also use it to track other really important public health considerations, like the use of methamphetamines or diabetes incidents. And when you think about the system, we're doing it right now, as Amanda said earlier, we're gathering this information at the end of the pipe at the treatment facility. Dr. Holden and her colleagues are really interested in the potential for upstream sampling throughout the system so that you can begin to isolate. You can look at incidences of all sorts of public health matters in neighborhood contexts, in localized areas. So if we do have a new infectious disease outbreak and we're able to track it back to a small part of our community and isolate it and have an appropriate public health response at that scale, we avoid incredible disruption to the community if we were, say, to have a much larger shutdown. Or if we have incidences of public health matters related to substance abuse or issues like diabetes, where we can create really localized service responses and show up in service of a community the way that would be most effective. Obviously, there's privacy concerns. There's all sorts of things that layer on here that are really sensitive and important to consider. But having that kind of local capacity to be able to do that sort of thing could really revolutionize how we treat public health collaboratively across agencies and jurisdictions in the region.
Dave, any questions?
No, no real questions. I think the opportunity for the concept of a regional lab is really exciting. I think that we obviously would want to, I would see the city continue to partner in that regard. The contribution of, collection staff and analysis is something which we've shown that we can basically work collaboratively to do. My real question is, in terms of the next steps relative to state and national program, what is our next step?
So I think today we wanted to kind of open up this dialogue, get it going. Depending on where the conversation goes, maybe we need to go back and do some more homework and research, and then bring back what I hope to be a recommendation for the Water Commission and ultimately the council as to what our role should be going forward. So I think that's where we're hoping the conversation would go today, is trying to figure out how that looks and who we need to be talking with to kind of formalize that, because I think everyone here recognizes that there's an immense value to this. We're in the business of protecting public health and the environment, so are they. And I think we've got a new tool to do that, and trying to figure out what our roles are in this new world is kind of the discussion today. And maybe we're not going to answer it in the next month or two, but it's trying to figure out and grapple with that, because certainly we have funding sources and they're constrained and limited, and trying to figure out how those, how we work together with our public health professionals.
Mr. Chair, I think it's clear that, again, we're very supportive of moving forward. I'm very proud of what the staff has done in working with the community to date, and thanking our partners here basically for stepping up. Again, if we need a motion, basically, to have to refer this to come back at an appropriate time, I'd make that motion.
Okay, do we have any further discussion? Or we can take a second on the motion, maybe we have more
Second.
discussion? A second. A little more discussion on the motion? I mean, I'm. A little more direction on what you want. A little more direction. I mean, I think it's important that we explore the county's role and the cottage health system role. I haven't heard anything about that. I mean, cottage health does a lot for the community and other aspects, and I'm just kind of curious, have they been approached to contribute to this? If they haven't, I think maybe they should. If they have and they've responded, what's been the response?
Thanks for the question. So Cottage has contributed to this. So Cottage has actually, we have, the population health team has been a partner in this. And Cottage has certainly directly used this data also. And so I think Cottage is absolutely at the table. I think that, yeah, so I think maybe that answers the question. Is there a more specific question?
Well, we're looking for money.
And
So I'm sure they're supportive of the program. I think that's kind of what this boils down to.
So I am a clinician, and I will
Yeah.
speak to the clinical part, and I'll defer to I think the commission I'll defer to Amanda. I mean, I'm a clinician, so I'm here to speak to the clinical aspects of it. But thanks for the question.
Okay, all right. I thought maybe you had heard publicly, the Cottage Health System's position on contributing financially.
I'm the medical director for
Right, okay.
population health, and I'm a clinician,
All
so
right.
I apologize for misunderstanding on that.
I can speak a little bit to the finances if you like. The team here, voluntarily, you all committed capital budget to do this work over the last couple of years, and it's been extraordinarily valuable. And it's unusual. No one else has really done that in the community. What you see now with the national efforts are opportunities to tap into other funding sources, outside funding, to amplify this and to do more funding and do more frequent sampling for other viruses as well, to be a part of something. I think that's a very compelling opportunity. And I am not an epidemiologist. I'm a nonprofit executive director. But who brings together these kinds of collaborations. I think that's a tremendous opportunity that you all should seriously consider joining Lompoc and many other communities regionally and nationally that are a part of that network, and accessing that funding. That funding traces back to Google and other big sources out there. So building on the great success that you all have had and the investment that you've made to now step into some of those larger partnerships, even though we don't know for sure how long those funding sources are going to continue to be available. My guess is that that's building to some larger, probably federal program, potentially with large philanthropic or corporate support alongside of that will continue and expand wastewater surveillance because of its incredible value. So even though we only have visibility for a certain period of time, my bet as a nonprofit leader is that's going to be expanded upon over time. And then meanwhile, we would love your ongoing support. You all wrote a letter of support and for the application that we put in earlier for the new wastewater surveillance laboratory here locally. We would love to talk to the council, to other city councils, to the commissioners or the Board of County Supervisors. I work in other counties that have commissioners, not supervisors. I always have to double check. But we would love to expand that conversation about how we build a true regional partnership to share the costs of building and operating a local wastewater surveillance system, such that Chair Young, there's an equitable participation amongst many different players in the system, and that nobody's bearing undue portions of the cost themselves. I don't think anybody's here to expecting the city of Santa Barbara to bear the cost of that, for instance. That would definitely be a regional shared program. And it's really admirable, again, commendable. I want to congratulate and appreciate you all for having invested in this data gathering exercise thus far, because it's been incredibly valuable to the community. I also should say we raised $20,000 from donors to supplement that, from individuals in the community who saw the value in it and wanted to supplement that and build the dashboard so we could publish that data, so that the graphs that Amanda and her team were producing weren't only available to a handful of people, and that's been very much appreciated. So there has been some supplemental or side-along funding already raised, and as we move forward, I expect that we'll be able to do that considerably, if in fact we kind of hit that threshold moment where we think we can raise the money to build the bigger program. Right now we're below that, so we're all doing day jobs. This is sort of a side hustle for all of us. It's something that we hope will happen, but it's not something we don't have any funding for ourselves to commit to it. We're just showing up in service of something that's an important public need.
Cora is next.
Okay, go ahead, Cora.
And then Dave.
I just wanted to kind of build on, Dave, your idea of a motion and putting some detail behind that. I think it might be helpful to understand with a little bit more detail how much the city is currently spending on this program from both like direct financial contributions and also staff time, and some perspective on, is that sustainable? Is that something that we are interested and able to continue at that level, or what would it take to do more, or does the city, is that not at a currently sustainable level to go into the future, so that we can get a sense of that. And I think also coming back to the concept of a regional lab, if we were to have a lab at UCSB that had a business model where it was somewhat self-sustaining, and how that would then impact the role of the city and the water and wastewater team, I think that would be really helpful.
Chair Young, Commissioner Snyder, we spend annually about $25,000 a year on this program, and that's including lab staff time. So right now, because we only sample once a week, the staff time is really limited. However, as you've heard from our experts, more samples are probably needed to really make better decisions on their part. So that new program that the CDC has put together requires us to do 3 times the sampling in the week. However, they are compensating us with the staffing budget and the shipping budget of that, and that is for a year. So the summer of 2024, if that's the way that we want to go, and still try to figure out where this new emerging industry is going towards. I think we have a lot of questions because it is so new, and there's value, but we don't have the funding to support that value just yet.
Well, and I reflect too that pricing just reflects testing for COVID RNA, and I think that the conversation today is just how do you branch out, and I'm sure the costs go up quickly with that over time. So yeah, I mean, we can take a look at that some more. I heard something today that was interesting because, again, we've been partnering locally. I didn't know if it would be disrespectful to stop that whole effort and pivot to these other folks. And again, we've been working closely. It's a different relationship. So the data would be going to someone else, and they'd be doing the analysis. And that's good. Okay, great.
Dave?
I was just going to clarify my motion. Everything which has been spoken, that the support for continuing the program and with respect to investigating state and national program collaborations, identifying opportunities, costs, and potential funding. That's what I'd like to see come back.
Okay, so I just have a preliminary question, and then we're going to vote on this, because I want to make sure I'm totally clear. If we were to get, say, 3 weeks in a row of very high spikes in COVID, can you just explain what happens with that data in terms of translation into action in the community? And I think I've heard the bits and pieces from both of you, but maybe you could give us the executive summary. Go ahead.
Thanks. That's a great question. So that's happened.
Yeah.
It very quickly leads to a response. And so I think going forward, as we talked about earlier, I think there's ways to do it better than we've done it, but here's what's happened so far. Here's what would happen today. If your hypothetical, Chair, I believe, is next week the data goes hugely different than this week, and the following week the same, and the following week the same. What do? We see the data. We talk to Dr. Ansorg. Dr. Ansorg, as our public health official, who I speak to almost daily, we look at the data. We get the disease control team together. We look at what's going on with case rates in the community, what's going on with hospitalizations, what's going on regionally, what's going on nationally, and we make a decision how to interpret that huge spike. It has direct impact on policy. It has direct impact on decisions within hospital systems, on decisions with regards to people getting together indoors without a mask on. It has direct impact potentially ahead of a coming surge, perhaps by 1, 2, 3 weeks. Now, part of why the question's a hard one, but it's an important one. It's a figurative one. Part of why the question's a hard one is that happening in a vacuum without there being other, perhaps, signal to help inform the decision, I think is difficult to imagine. But if, for example, we were starting to see some movement that there was potentially a surge coming, and then there was to be a huge spike in the wastewater data, that would tell us on the ground, as clinicians, as public health folks, that would tell us that it's here. And if there is to be a response, I will not speak as a public health official for what the response would be, but if there was to be a response, that now is the time to ask those questions and make those decisions.
So the response is you tell local healthcare practitioners, hey, we're seeing the potential indications of an infection in the community. Start being aware of it when you treat people or see people. Start considering testing. And there's a resource allocation discussion that goes on within the hospitals. Is that kind of what?
Certainly, but in addition, even before that, I'm very respectful of the role that our public health department has in all this. It may well be that Dr. Ansorg and his team actually chooses to do to take other measures, to perhaps communicate to the Board of Supervisors regarding a recommended shift in perhaps public health policy or public health advice. It has that level of implication. And again, the example's a dire one. And I don't want to be alarmist, and I don't mean to, I think, be painting an extreme picture that we're, at risk of perhaps a looming explosive COVID surge next week. We're not. We're in a good place with COVID right now. But where this has moved, in large part thanks to your incredible team here and your support, where this has moved is that in the years ahead, this is absolutely part of the public health, population health landscape, and it's a powerful tool. And I'm, as a clinician, grateful for it because it's going to inform public health policy and clinicians.
I agree, with all that, completely.
Thank you.
Can I
Yeah.
jump in before we do the motion? Or
What's
I'm
that?
so sorry.
Go ahead.
Sorry, kind of to bring back with the decision-making question, and an anecdote you brought in at the beginning, I'm so sorry, but, you said like right now, obviously, like we shouldn't be worried about like Marburg virus, right? So we're not testing for that because of course we don't have unlimited resource and unlimited whatever. Not that specific virus, but what in the future if we have this sort of program and we have funding and we have a a not unlimited budget, right? At what point or how would those decisions be made? And this might be way too hypothetical to say like there is something new emerging that we need to now include in the data that we're looking at.
Thanks. So the one I'm most worried about, if I'm being honest, is polio. We as a community do not have outstanding childhood vaccination uptake compared to other communities. And that's of course I'm speaking as a clinician, as a public health epidemiology focused person. We have lots of well protected people in our community, but we have some who are not. And we know that poliovirus is not gone from the world. In fact, there are pockets where it has been emerging, including here in the United States. I, as an infectious disease physician, I didn't mention, but another hat I wear, my primary role actually is I'm program director for the residency program at Cottage Health. And so actually between the cracks this morning, I'm here, I'm grateful to be here, but going back over to round on my inpatients in the hospital, and patients that we see in the hospital often have something called Guillain-Barré syndrome, perhaps botulism, some of these other neurologic problems with the peripheral nerves. I don't think about polio today. If I knew that there was any polio in the wastewater in Santa Barbara County, when I saw that patient this week who had Guillain-Barré syndrome, I would think about polio. I hope that in our community we never, ever have a case of polio again. But as an ID physician, who I consider myself squarely mid-career, I've aged about 10 years in 2 years, but I hope to finish my career not seeing polio. But that's the one, if you're looking for a solid anecdote. I'm not worried about Marburg. Let's keep an eye on it. Let's make sure that that it's not something to worry about in the coming weeks, but I do worry about polio as an example.
Okay, any last comments before I call for a vote on the motion?
Sorry.
Okay. Madam Clerk?
Commissioner Davis,
Yes.
Commissioner Keller,
Yes?
Commissioner Snyder,
Yes.
Vice Chair Cooney,
Yes.
and Chair Young.
Yes. Great, thank you. That was really informative. I thank you all for presenting this to us. Kind of excited to see what staff comes back with.
Thanks.
Thank you.
Thank you. Thank you. So, any idea, estimate as to when this would come back?
I don't know yet.
Yeah.
Yeah.
I mean,
I feel like we gotta dig into it, some
Right.
good information, good discussion here today. We will be talking about it as part of our check-in, and we'll try and put some dates to it once we get a little more information.
you think it's this year?
Yeah, I think this year.
Okay.
Yeah,
I'm not holding your feet to the fire.
No.
I'm just,
yeah.
I kind of,
It's in the minutes.
you got me hooked. I want to know what the answers are.
Okay.
I like want to
Okay.
text her when I'm worried about things.
All right. We ready to move on, everybody? Let's see, where's my agenda? Thank you. Okay, let's see. Item 6 6B, direct potable reuse regulations development update from the California State Water Resources Control Board Division of Drinking Water.
Good morning, Chair Young, Water Commissioners, and Councilmember Sneddon. I'm Dakota Corey, and I'm the Water Supply and Services Manager. And as you know, direct potable reuse is a potential water supply option that we have investigated at different times in our water supply planning. We did a feasibility study in 2017 looking at the feasibility of implementing both indirect potable reuse and direct potable reuse for the city. And then when we completed our enhanced urban water management plan in 2020, direct potable reuse was one of the options that we considered for future supply. As you know, the state is still working on final regulations around treatment and the provision of direct potable reuse as a water supply. And so today we wanted to bring an expert in the field, Mr. Brian Bernardos from the Division of Drinking Water, to give an update on where the state stands with the regulations and answer technical questions related to future regulations around direct potable reuse. And with that, we'll go ahead and get started.
Go ahead, Mr. Bernardos.
Yes, good morning. I hope you can hear me.
Yes.
I'm calling in from San Diego, where I've worked for 30 years with the public health side of drinking water. For most of my career was in California Department of Public Health, and last few years been in the State Water Board. So I don't see my slides up.
They are up. It is.
Okay.
Yeah.
Oh, all right. I'm not seeing. Okay, well, great. Now I can see it. So I just wanted to explain that I'm a civil engineer and been in this field since 1992 and been working in both drinking water and recycled water. And so I was the district engineer in charge of San Diego and Imperial County for 7 years. On the drinking water side, as you probably know, Jeff Dinsmore is your local district engineer, and I work with him. Since 2007, I moved into a technical specialist position where I work statewide on advanced technologies. So next slide, please. So basically, direct potable reuse is, we want to have major goals to control both pathogens and toxic chemicals. And one of the ways that we are developing our regs is to refer to a 2016 report that was put out by an expert panel that the state assembled of experts. And that report is the expert panel on feasibility of developing uniform water recycling criteria for direct potable reuse. We wanted to take the first step to make sure it was feasible to come up with uniform criteria. And what we mean by that is we have uniform criteria for non-potable reuse, and basically anybody can follow our regs if they follow that existing criteria in Title 22, the water recycling criteria. So we're adding a similar thing for direct potable reuse where anybody in the state of California would know how to proceed to do a direct potable reuse project. So next slide, please. Now, we relied on these experts that were part of this 2016 panel, and they included people that were top microbiologists, top chemical risk assessors, toxicologists, and treatment engineers. And, there was represented some of the local colleges like Stanford and Berkeley and UC Riverside, and also, nationwide, Michigan State, Drexel University, and even internationally, Jörg Dreves is expert worldwide in Germany. So next slide, please. So in summary, this panel emphasized that direct potable reuse systems need features that exceed those for our existing regs for indirect polar reuse. As you're probably aware, we have two separate regs. One is a groundwater recharge reg that's, for instance, Orange County and West Basin and others are examples of that. And so that's been a reg since 2014, and there's quite a few projects in the state meeting that. But that goes through, a significant aquifer, and your staff has looked into that. We also have regs that are particularly applicable to San Diego County, and Las Virgenes is looking into reservoir augmentation with recycled water. And City of San Diego is moving toward augmenting an existing drinking water reservoir with highly treated water. But this would be a system where basically there'd be either no or very limited environmental buffers. So what they said is that, that type of system must be very reliable. It also must have a diverse set of processes, and they called that robustness. So different types of treatment processes that I'll explain later. And then the immediate diversion of any off-spec water and averaging of potential chemical peaks they identified in that project, in that report. So next slide, please. They also recommended some research. And so the state and other people have spent millions of dollars to do these 5 projects. And I'm not going to have the time to go in detail, but I'm going to talk about number 1 and 2 were very important for pathogens, and number DPR 4 for chemicals. Next slide, please. So obviously the main focus, of course, is pathogens. As you heard earlier, we want to know what's in the wastewater, and that was an excellent presentation earlier. I listened into all that. That was fascinating. We actually did something similar in our DPR 1 and 2, where we looked at actual pathogens like Cryptosporidium, Giardia, norovirus, adenovirus, and other things. And so that was very informative. Next slide, please. So what we came up with, based upon the data that is raw data going into wastewater treatment plants. So before any treatment, we have six large utilities in California collect for 14 months, and we got a very good database. And based upon that, and based upon a microbial risk assessment, there was a tool provided in one of those research projects to help us interpret the data. And what we came up with is for direct polar reuse, the basic minimum that needs to be achieved is 16 log of virus removal, 10 log of Giardia removal, and 11 log of Cryptosporidium removal. And if those are not met, then the DPR plant would have to discontinue delivery almost immediately. Now, we also have a second level where we want them to be operating at a higher level, which is 2014-15. And they should try to do that, but at least be above 90% of the time in the month. And so that provides a buffer, because if you lose one major treatment train, we did an analysis based upon our risk assessment. If one of the major treatment trains, such as UV, for instance, was to go down, and if for some reason the immediate response didn't happen to divert, you'd have a buffer. And so we added this 4 extra log for all of these. And I'll refer to our link there if you want to know how we got to those numbers. I don't have time to go into all those calculations, but that's probably the most important part of our regulation, that each of these different treatment trains will add up to these log removals. Next slide, please. Now, in addition to that, we want 4 treatment processes for each of the 3 pathogen categories. And those 3 main categories, which is pretty much what we do in indirect polar reuse, we focus on Cryptosporidium, Giardia, and viruses. And we're probably targeting specifically adenovirus, but adenovirus and norovirus, we think we're addressing both of those, and those are the two ones we kind of think are the most important. And so 4 separate treatment processes that have at least 1 log removal from those processes for each of those 3, Cryptosporidium, Giardia, and viruses. And at least 3 different mechanisms. And so we identified physical separation, chemical disinfection, and UV disinfection as minimum for reliability of pathogens. And I already explained these other 2 points. Next slide, please. So there is a difference that I wanted to point out, is that there is what people call raw water augmentation, and another is treated water augmentation. And so we basically are going to have one regulation, but raw water augmentation, which generally means it could be a small reservoir preceding an existing surface water treatment plant, does have some benefits. And we could allow some credit for that reservoir if it's significant enough to provide up to one of those 20, 14, 15, or 16, 10, 11 levels. Okay. And besides that, there's also some advantages to the reservoir because it provides some dilution and ability to attenuate some peak chemicals. I'll talk about that later. And there's other quantifiable benefits that could be demonstrated via dilution in the reservoir. Next slide, please. Now, in addition to that, a raw water augmentation is defined as upstream of a drinking water plant, which we assume the statute means a surface water treatment plant. So for an existing surface water treatment plant, which you have one, there's obvious benefits toward the raw water augmentation project. For instance, free chlorine disinfection is extremely effective at inactivation of viruses. And, you know, the existing regs in the EPA surface water rule require, some disinfection of viruses, and chlorine also can provide some Giardia inactivation. It doesn't provide any Cryptosporidium. It takes other processes to do that, but there are some advantages of having a surface water plant that has chlorination. Okay, next slide, please. So here's an example of what the 2016 report included. They included this graph, which is from an incident at Orange County in 2013, where all of a sudden they had a pulse of a chemical run through their plant that lasted, most of the day. And they saw that because they have online TOC at the influent, where, as you can see, it was trending, about 8 to 9 TOC. It peaked at 21 at that time. And the most dramatic was that this chemical actually went through both the RO and the advanced oxidation. And it went from the TOC at the effluent, which is typical at Orange County, to less than 0.1 milligrams per liter, up to 7 milligrams per liter. So that's an increase of 70%. And this was not, of course, a public health issue because it was going into an aquifer. And, analysis determined that it was acetone, which is not that toxic. Obviously, that's used a lot at nail salons, so it doesn't pose an acute threat in general. But we worry about that for direct potable reuse because there's no environmental buffer. Like the Orange County, they have 6 months of travel time in their aquifer, and the acetone was not detected at all. So that's why the panel said we need to address this type of potential chemical peak issue. Next slide. So moving on from pathogens to the chemical control approach, we want to have enhanced source control and public education around what people are using in their personal care products. Obviously, we want to conform, as we do in drinking water, for all the maximum contaminant level chemicals and a notification level requirements. Needs to be monitoring done on a regular basis, and the potential to develop additional notification levels as appropriate that we find in wastewater. Want to have multi-barrier advanced treatment. I'll show that later. And of course, address especially pulses of low molecular weight chemicals. Acetone happens to be one of the few things that is a very low molecular weight below the RO cutoff, and it's not degraded by UV. And so you want to have actual treatment process control points with critical limits that identify that the process is not optimally working at its best. And so you can respond to that with a quick response plan. Next slide, please. So what we want is a good source control that is administered through a joint plan. And in your case, you may not need a joint plan because it may be your wastewater people and your city water people are within city of Santa Barbara. Like, that's the case in San Diego. But in other places, there are, in many places in LA, there's a separate sanitation district from the drinking water district. So we want to have those two coordinated in a joint plan, and they need to agree on what source control needs to be done. And we want a sewage bed surveillance program as part of that joint plan, which could be, microbes, as was discussed earlier today, but we're also mostly focused on chemicals, where we want to know, is there an industry that's going to discharge something, we would be able to catch it and respond to that. Because we don't know what that acetone pipe, there was no way for Orange County to figure out who actually was dumping acetone at such a high level in 2013. So that's still a mystery, but we want to have a surveillance program to try to have an early warning of something like that. Next slide, please. So we've added requirements that are specific to source control that are beyond the EPA limited pretreatment, which is focused on certain industries. We want to try to address anything that could be a risk to public health. And so the typical way to do that is to utilize local limits. And for instance, Orange County has developed a local limit for 1,4-dioxane, which is not a national requirement, but it's an issue in their community that they know the industry should be controlling the discharge of 1,4-dioxane. So that's a good example of how to use local limits that's specific to your area. There needs to be regular audits, some sort of early warning of potential peaks. Should be a source control committee and continuous improvement process of that. Next slide, please. So we created a specific expert panel on source control, which included these people, which are well known in the industry, and both nationally and internationally. And next slide, they came up with certain recommendations that we've added to our reg. And they said it's critical and very significant to try to identify illegal discharges that occasionally might happen. And these can be detected via some sort of a monitoring system. And we're not specifying exactly what that monitoring system is, but there are a lot of research into that and has been proven to work. Your neighbor in your city, Ventura, has been a leader in that. Next slide, please. And then we wanted a third robust chemical. So our existing, in the case of indirect potable reuse, where there's recharge with is direct injection, not spread in ponds, but directly injected. And most of our projects in California are directly injecting it into the aquifer. We want reverse osmosis and advanced oxidation with UV. So they said we should have a third process. Okay, next slide, please. So what we are saying in our reg, the treatment train must have at least 3 separate treatment processes for chemicals. And that includes 1, a ozone biologically activated carbon process, and that's upstream of reverse osmosis. And next would be advanced oxidation with UV. Next slide, please. So this is sort of what it looks like. And what you basically have is 3 separate robust mechanisms. The ozone biological activated carbon is primarily not only disinfection, but it provides biodegradation of things like acetone and formaldehyde. And then separation, the RO is the main workhorse, which most chemicals are removed by RO. And then anything that gets through, like 1,4-dioxane or NDMA, is degraded by advanced oxidation with high-powered UV and either peroxide or free chlorine. Next slide, please. So what is publicly available is a August 2021 that is available on our website. And so at that time, we were thinking we were following the City of San Diego project, which has had a demonstration project for over 10 years, and they were looking at ozone BAC. And so it was actually quoted by the 2016 expert panel, which gave us direction. And you can find it online. It's the WREF Project 1412. And San Diego approved that they could achieve a 1 log removal of formaldehyde, acetone, and NDMA using an empty bed contact of 15 minutes and an ozone to TOC ratio of 1.0. Next slide, please. So our existing expert panel is a lot of the same people that were in the 2016 panel have come back in the current panel that we have. We're required to run it by our regs right by them. And so they suggested some changes. And so they suggested achieving a 1 log carbamazepine and sulfamoxyl reduction between pre-ozone and post-ozone. And so that's kind of an indicator of the ozone process. And to continue with the 1 log formaldehyde and acetone, but drop the NDMA between the prior to the biologically filter, active carbon filter, and post carbon filter. And so the reason that these experts said is NDMA is already addressed by UV AOP. Carbamazepine does not easily biodegrade, so the ozone is great for that. And sulfamethoxyl, I'm sure your people at public health would realize that we were over medicated with antimicrobials like sulfamethoxyl, so it's usually present in most wastewater. Next slide, please. So then we have specifications of continuous performance monitoring of these different processes. So there's these ability to track certain surrogates that relate to an operational parameter that indicates when the treatment's performing as designed or an integrity has been compromised. And some of these things are commonly already used. So measuring ozone and TOC, and that ratio is a performance monitor. There's online absorbance monitors, online TOC monitors, and for UV, there's the ability to track UV dose or energy. And so all those are continually monitored, and the treatment experts, the operators can track these things, and alarms can be tied to these performance monitors. Next slide, please. And finally, I want to wrap up by talking about we want really good operators. And the current operator certification processes in California officially are drinking water certification and wastewater certification. And so those have certain things in the regs that are tailored to mostly surface water filtration. So advanced type of processes like membranes such as RO and advanced oxidation like ozone or UV is really not covered by the existing certification processes. So we want at least one operator to possess this new program called the AWTO, and it needs to be a grade AWTO 5. And that's being run by the California Nevada section of American Water Works and the California Water Environment Association. Next slide, please. So this is what we believe is a process where the operations plan should describe who the operators are and what their level of training is. And by having this AWTO operator certification, it's a test that proves that they know enough about membranes and advanced chemical things like UV and ozone. And the existing certification programs are kind of the starting point. And once you get to either a wastewater 3 or a drinking water T3, then you're eligible to take this AWTO test, which is a volunteer test, but we're going to put it in our regulation as an expectation so that we know that we have the best operators for these DPR plants. Next slide, please. And I wanted to point out that this was something that's been worked on since about 2016, and the city of Santa Barbara was represented on this panel. What was her name? Kelly Dyer. I don't know if she's still with you, but she's in this picture somewhere I think on the right. Anyway, so we had a good representation all throughout the state, and it's an excellent program. I think that's my last slide. Next slide. Oh, okay. So we do have some alternatives that we would consider. Mostly that is involved with chemical control. We are considering, based upon water reuse comments, some broader alternatives. And so that's why our final reg is not quite out. We are planning on the next month or two having a final reg go out for public comment, which is the official process the state of California uses, is where we publish and ask for a 45-day comment period from anybody in the public. We've been getting comments already from existing water and wastewater agencies. And we think that there's certain critical things that shouldn't be alternatives, such as the level of pathogen reductions that I identified earlier. And we don't want somebody to say, oh, I won't respond to an immediate off-spec water. We want to make sure that things are diverted before it ever gets to the public. And we don't want to compromise on the technical, managerial, and financial capacity. So each DPR will have to prove that they have all of those capacity to actually, build a plant, operate a plant, and maintain the capital to replace things like RO membranes and UV bulbs and things like that. So, and we're trying to be very conservative and health protective. I think that's probably my last slide, and I can answer any questions.
Any commission questions or comments? Councilmember Snedden.
Thank you. I guess my first question is, thank you for the presentation, and are we framing this as what is our consideration here at this point? Is a high level of detail? I have some questions about the detail, but sort of the end product, where this goes.
This is an informational item. Certainly, it's something that we're investigating and continuing to follow the science. Really appreciate Brian taking the time to talk to us today, keep us up to speed on how that's developing. Want to talk about the truths of the challenges ahead. This is not an easy venture. There are certainly some big players, as Brian is located in San Diego now and following their process and going through that. They have much more resources than we do, so we're looking to see some of these big players kind of go through this and vet it. But I think, as we've been talking about for years, we've been making decisions that align with this. Our $30 million investment in our secondary improvements was to stabilize our effluent so that someday this could be a possibility. We already implement ozone and activated carbon at our surface water treatment plant. So it's a technology we're familiar with. And our staff is familiar with. So again, it's all, we use UV at our desalination plant and RO. So all of these technologies that the city is utilizing now, getting familiar with, and as Brian was pointing out, we see those crazy spikes every so often in the wastewater stream that we can't explain, and then having source control measures put in place is going to be part of how we get there. But I think just starting the conversation, keeping the conversation going, because it is recognized in our urban water management plan as a future supply for the city, and I think there's an opportunity to get more information out to the public. I don't want to scare anybody, but let's have a conversation. Let's get this information out there. I probably have just as many concerns as many people would have, and it's how do we slowly work through those challenges?
Thank you. So then that, it's sort of interesting, these two presentations today back to back, because it raises all the questions of pathogens, I think in particular, but also methamphetamine or different pharmaceuticals in the wastewater. But with the pathogens, I guess my question is, when we you've been looking at this for a long time, but when I first was looking at this here, COVID hadn't happened. And so the idea of like a pandemic or some new virus, something we're not aware of to be even testing for, and if you could just talk about our guest speaker too, about how would that be addressed? So that's one question I have. And then the other is anybody doing this yet? All the way, all in? And if we could hear about
Brian, do you want to take a stab at both those questions? Because I think you probably have more details than me on that.
Yeah, sure. So we assembled, like I said, these experts that are microbiologists, and the determination was that we wanted to sample for the things that we know are there: norovirus, adenovirus, other viruses, and Cryptosporidium majority. And those are the most challenging things in the water field, and so that's pretty much a consensus that if we deal with these type of pathogens, we're dealing with other things. So for instance, it turns out that I did a lot of work on the COVID, virus, and it turns out that it's actually very susceptible to our treatment technologies. Chlorine and UV is very effective on that compared to adenovirus, say. So we were very well protected. The reuse that was already happening, there was no concern for the COVID virus getting through our treatment processes. So we have some really robust, and I want to point out these processes are expensive, but they are the best processes, and we believe that because they are so robust, that we feel that any future pathogen will probably be addressed. Who knows for sure, but so far so good. And who is doing this? I'm probably going to pronounce it, but in Africa, there's been Namibia has been doing it for years, but that's Africa, so that's whatever your opinion of that is, that's up to them. There is a small town in Texas, Big Springs, which is sort of doing this, but it's a mixture, so it's not exactly. They're mixing it with a lot of surface water, so it's not exactly what we're talking about. City of El Paso is maybe the first that'll come online in a couple of years in Texas. But Texas has sort of a case-by-case review by their state regulators. We're trying to develop a uniform code where anybody in California will know, okay, this is what we need to do. whether you're city of San Diego or a smaller city, anywhere. We're not limiting it to any size particular city. We're trying to make it so that any utility that has the capacity to build and operate and maintain could do this. And so we have some, as you saw, some really high level expectations. Up to 20 log virus. That's a lot of kill of virus, and some people think that's excessive. But we believe that that's what we need for protective, and we have a lot of conservatism built into that. So, in our opinion, we can tell the public that this would be safe for them to drink.
Thank you.
Arturo.
Yes, thank you very much for this presentation. Very, very informative and very interesting. So, it seems like with the different treatment train technologies that you're going to have, it should be very robust in terms of being able to deal with everything. But the question always is, if they're working, I think we're pretty much safe. But what happens if they don't work? And so that leads to thinking about what would happen in those cases. And I'm wondering what the regulations will have in terms of requirements for redundancy in some of these treatments. So redundancy is one thing. The other one is the online monitoring. So you mentioned, for example, TOC being monitored, but TOC is monitored at a fairly high concentration for some of these small molecules that we're interested in. And we have probably about, you've identified 3 or 4, but there's probably about 30 or 40 different small molecules that are of concern today. And our big concern is, of course, we keep on coming up with new pharmaceuticals. So we have to sort of be thinking about not just the current ones, but what may be coming down the pipeline, and how do we keep track and be able to monitor them on a real-time basis, because we don't have a lot of time between the end of the pipe and then the delivery to the customers. And then the third one is that emergency reservoir, emergency buffer. What kind of size do you think the regulations will require for the emergency buffer, so that you can handle being off spec, putting it into that emergency buffer for how long before you make the decision to shut down or to you can go ahead and proceed? So what are your thoughts on those?
Well, that's a lot. We have, the first question, I think, was what redundancy? And
yes,
so
redundancy, yeah. Mm-hmm.
That's what I was showing. So the basic minimum requirement is the 16 log virus, 10 log Giardia, 11 log Cryptosporidium. We added 4 for each of those to go up to 20, 14, 15. So we have a 4 log redundancy that so for instance, what we looked at was the advanced oxidation UV is probably the one thing that, the electricity or the bulbs could short, and we have seen that happen in California, where a whole train went down and it wasn't noticed for a number of hours. And so we looked at what would happen, and so that 4 log redundancy would have provided enough protection at the the 10 to the minus 4 infection. So that's what we use, the national, and so the operating at 20, and if something failed, the worst case, you'd still have the 16 log virus kill. So we have that 4 log redundancy. Okay, and that's quite achievable with these processes. The next question was, I think,
online monitoring of small molecules.
Small molecules.
Yeah, online monitoring of small molecules, but a range of them, because there's many that could be there.
There's a lot of experience over the 30 years now with RO and treatment of wastewater, and very few things get past the RO. What does get past is the small molecules such as 1,4-dioxane and NDMA. And so that's why, in Orange County's case, they added the UV, which UV plus the hydrogen peroxide degrades the 1,4-dioxane. And the NDMA is addressed by UV alone. And so what these experts on this panel, that are worldwide experts, said, if you're going to reduce, by reducing 1,4-dioxane to a certain level, you're probably addressing most things. that might get through, that you may not be monitoring for them online, but you're operating your advanced oxidation to provide a lot of degradation that should address any CEC that we're aware of. And so that's pretty much proven true. The exception, as I showed, was the acetone was able to get through. Great acetone is a small molecule, but it's not toxic. And another example would be formaldehyde. So that's why we've added the third process that addresses those things that we have seen get through RO and advanced oxidation. So we think having these three diverse mechanisms will address anything. And there's been a lot in monitoring for pharmaceuticals. Actually, pharmaceuticals are not, in my opinion, our biggest worry. It's more the solvents and chemicals from industry, because the monitoring, there's been the work by the CEC panel statewide. There's been 2 reports, and actually very few things get past the secondary treatment if it's good secondary treatment. Most of the pharmaceuticals don't show up. There are a few like carbamazepine and sulfamoxyl that I mentioned that do show up in the secondary process. They happen to be big molecules in most of the pharmaceuticals. And by the way, there's a lot of worry about the perfluoridated substances. Those are all very big molecules. The typical RO cutoff is 200 molecular weight. And so most of the organic chemicals are above that. And like you said, there are a few that we know of. And so we're addressing it with ozone BAC and UV advanced oxidation, which are very robust for these different chemicals that maybe even unknowns that we think could be there. So
Brian,
the TOC, the RO, by operating at a low TOC, it is removing a lot of stuff. And so, for instance, we have 3 triggers. I didn't get into this, but we have actually 4 triggers for TOC. If it goes above certain levels, first of all, you need to start investigating, what's happening. And then maybe you take the RO offline to do some sort of conductivity probe. So there are measures in our reg to address a response to a TOC that could go above 0.1 and another for 0.25 and so forth, and I didn't go into all those details. But we have these certain things that are tied to critical limits that then we know the RO isn't performing right, or the ozone is not performing well. So, absorbance is a good indicator. The ozone to TOC ratio is a good indicator. And the UV has certain indicators that have been proven to be very good. There's a lot of energy that, I was just at some installations in LA where the dose to deal with some of those chemicals, and of course this is a cleanup of some of the legacy chemicals in the San Fernando Valley. Their doses are going to be 3,000 compared to 300 to 1,000 for most advanced oxidation. So depending on what the chemical is, and we're using 1,4-dioxane, usually a dose of 1,000 plus a certain amount of peroxide will degrade most chemicals.
Brian, do you know if the FDA is planning to do anything in their drug scrutiny process to identify if there is any potential issues, like in particular, how these drugs break down in the human body or pass the human body? Was that any part of the conversation, or is it was deemed so that there isn't really anything the drug industry can come up with could get through these processes?
Well, we certainly want to know what the most popular chemicals are, and so and do some regular monitoring for them to track them. But our experiences is that these chemicals that I mentioned are pretty well addressed by these advanced processes, and the breakdown of them, that's an interesting question. What is the metabolites of these drugs? Well, So there's new research into bioassays that are being done. And so you might be aware that there's certain required bioassay testing to be done at these total reuse projects. And that's still a field where you basically, if you see something in the bioassay, then you try to determine, is that a chemical you can find? And so that's a long discussion that I don't have time to get into. But that's, you know, at the national level, people are looking at bioassays.
Okay, any last comments or questions from my colleagues? Okay. Mr. Bernardos, thank you very much for your time and presentation. That was really informative. And thank you to staff for putting this on. My questions have been answered. I can now sit back and let things evolve as they are going to evolve. All right. Moving right along to agenda item 6C, amendment to increase the on-call engineering services contract for Pueblo Water Resources, Inc. Mr. Hagmark.
Chair Young, I'll go ahead and take this item. Again, Dakota Corey, the Water Supply and Services Manager. We just wanted to give a little bit of context for this increase in budget to an existing contract with Pueblo Water Resources. As you know, through our work in our Enhanced Urban Water Management Plan, our groundwater resource is a super important resource to us, especially in times of drought. And this contract with Pueblo allows us to continue our work in managing those resources the best way possible. It's going to allow us to restart our ASR injection pilot program in the Foothill Basin. So you're aware that we had started that project, and then one, due to some pump failures at the well, and then two, because we needed to turn our groundwater wells back on, we had to postpone that project, but we're going to restart it again in April. So there's budget in here for that. And then we have some other investigations that we would potentially like Pueblo's support on regarding looking at the feasibility of potentially siting some new wells in the Foothill Basin. We also want to analyze the feasibility of the assets that we have from the Lincolnwood water system, in which we just connected to the city's system. So those are some of the different scope of work that it would be available to Pueblo with this increase to their contract. And I'm happy to answer any questions you have about that.
Any questions? Okay.
What's just one question, Mr. Chair? As I understood, this is a contract for 2020 to 2025. Total amount now would be $1,000,001, with the increase amount $750. So the original contract was only for $350?
I think the original contract was $250. We added $100,000 to that, and then now we're increasing it again.
Okay, and that degree of increase, is that due to the types of projects we have coming up?
Yes.
Yeah,
Mhm.
okay.
Okay, so we need a motion on this recommendation.
I move staff recommendation.
Second?
Okay. Madam Clerk?
Commissioner Davis,
Yes.
Commissioner Keller,
Yes.
Commissioner Snyder,
Yes.
Vice Chair Cooney,
Yes.
and Chair Young.
Yes. Okay, thank you. And let's move on to sub-item D, contracts for construction of the Braemar Lift Station Rehabilitation Project.
Yeah, so excited to have this project headed into construction, and want to just take a few minutes to have staff kind of run you through what will be happening to the city's largest lift station. And with that, I'll turn it over to Amanda Flessy.
Morning. Again, Commissioners, Amanda Flessy, Wastewater Manager. Very excited to be here with Mr. Philip Maldonado, our supervising civil engineer, to bring the contract for construction of the Braemar Lift Station. I should have brought some champagne. I'm sorry. This is really exciting. I'm very excited for this project. No. Put some orange juice in it. It'll be mimosas. So now I'm going to turn it over to Mr. Maldonado to kind of just give a little bit of background at Braemar for those that aren't familiar, since this has been around for a long time. So,
Yes, thank you. Thank you, Ms. Plessy. Chair Young, Commission members, Councilmember Sneddon, good to see you again. And yeah, to begin, we'll provide a little bit of background for the project along with the overview of the completed elements, current work underway, and describe the planned construction work timeline and budget. The photo you see here is an aerial view of our Braemar lift station. The facility is outlined in blue and located in the corner of Allen Road and Cliff Drive. The photo exemplifies the sensitive location of the project adjacent to Arroyo Burro Beach, on a small parcel in a residential neighborhood. In the next slides, I'll review the goals of the project and highlight why it was prioritized. Next slide, please. Now, stated on this slide, the goal of the project is to eliminate the risk of failure by replacing aging infrastructure. Through the design effort, we have identified ways to improve system efficiency while also eliminating single points of failure. One area of efficiency will be energy savings through inclusion of variable speed drives for the pumps, of course, being the primary energy demand for this facility. By reconfiguring piping and replacing all of the electrical systems, we will improve long-term facility resilience and reliability. The rehabilitation of the system was identified as a top priority amongst the other pumping systems throughout the city. And due to its location, sea level rise and its impacts had to be considered to ensure long-term operational security. Next slide, please. Let me begin by providing some background on the current project. The image on this slide is taken from Cliff Drive, facing the station. The station is the smaller building in the foreground. It is designed to blend in with the surrounding neighborhood with a minimal footprint on the parcel it occupies. It is the largest, that being said, it is the largest lift station in the city. The design will replace or rehabilitate all of the functional components of the system. The design effort focused heavily on construction staging to minimize impact in the area while keeping health and safety as the highest priority. As the largest lift station, the system serves parts of Hope Ranch, Campanile, and Allen Road neighborhoods, as well as Arroyo Burro Beach. The service area is bound by Modoc Road to the north, neighborhoods along Las Positas on the east, and Hope Ranch to the west. So just give you a feel for where it's located and who it serves. The design has identified 3 distinct stages of construction to complete the project while minimizing impacts. And those stages were actually reflected in the preliminary schedule received from the bid that we're going to talk about. Next slide, please. So this leads me to what has been completed thus far. The project completed design and building review. Staff selected a construction management and inspection consultant prior to bidding, and this allowed that construction manager to become familiar with the final design and perform a constructability review. Those constructability review comments were included in the final design package prior to bidding. In parallel, the funding agreement was finalized at council on January 31st, and project bids were received February 9th. The apparent low bid is from Cushman Contracting and is for $6,476,626. The bid has been reviewed to ensure compliance with contracting requirements, and I should note the proposal of approximately $6.5 million is significantly higher than the engineer's estimate of $5.1 million. That said, the discrepancy is not completely surprising, just given the market volatility that we have seen in recent years, plus the relative age of the engineer's estimate, which was about 6 months old at the time. We are working to amend the funding agreement to include these additional costs, and I will discuss more on that in a later slide. Next slide, please. So the current work. Moving forward, there is plenty remaining to accomplish. The construction contracts are scheduled for approval at council March 21st. Once the construction contract is in place, the first priority will be to set start date and determine the construction schedule. We anticipate long equipment lead times and several details to coordinate the construction sequencing. So these details will help direct effective outreach to the neighborhood and community. We plan to layer multiple types of communication to ensure the community is informed as much as possible and has a clear expectation for the anticipated impacts. We anticipate having time for these efforts because of that long lead time. And as you can see in this photo, mobilizing on this site has a clear impact to this intersection and the surrounding community. Driving lanes are narrowed and construction activity is easily extends outside of the property boundary. Staff will stay focused on keeping this organized and communicating larger disruptions. What we see in the photo is a bypass pumping of flows entering the facility. We like to highlight this because we anticipate several bypass configurations along with continuous pumping while the contractor is mobilized and actually doing the work. And that'll continue for about a year. Next slide, please.
I just want to emphasize to you all, you will see this configuration for about a year. That's the impact to the community, and that's really what we want to emphasize because of that bypass pumping. That bypass pumping, we have to put it in the streets so we can do our work that's in the wet wells and everything. So that will be there probably 9 to 12 months.
I'm going to move through this slide fairly quickly. Oh, yes.
We have a question.
If I may, I live very nearby, and I go by, and you guys do a great job. The community, I don't think has a major problem. I think it's very well indicated that, there's really no issue there. So even though it's disruptive, but it has been quite good, so.
Excellent. Much appreciated.
I also want to make the point that although we're going to be approving construction contracts, we won't see this for another year. So it will be a long time. You'll probably be like, what happened? We approved those, a year ago, the long lead times. So a lot of community outreach will be put forth, but then really put forth in a year when we actually come ready for construction.
And like I said, I'm going to slide through this fairly quickly, but this is from above, a view from above, but it really kind of highlights how even though there's a small building on site, there's multiple process areas that really take the extents of the site, those being the wet well, and then of course the dry well and electrical room, and then the valve vault that I like to identify, because those are the process areas that can help phase the construction. Wet well rehabilitation, dry well and electrical room for pump and electrical equipment that can be replaced, and then the valve vault and the piping that goes in and out of that will be replaced along the frontage. Next slide, please.
I also just want to add, your wells are underground and your vault's all underground, so you don't see that. The only thing you see from the pictures are your electrical room and your generator room.
Other areas important for the execution of the work, having a well-planned construction staging, and as I described on the previous slide, the work will need to follow those process areas in order to be implemented. Also developing a detailed bypass plan to stage the construction. Having these plans will facilitate safe work environment, it'll minimize impact, and ensure the community is clearly communicated to. And I'd like to point out one of our operators actually took this photo, Gerardo Soria, but it gives us a good vantage point, looking at the pumps, the complexity, and how tight the configuration actually is. Next slide. This image right here is from above the pumps. So again, with people in the image, it gives you that context of how tight it is in there. The timeline for this project has changed. As we all know, the original, we previously planned to implement this project in 2020. As with many things, we were delayed by the pandemic. That said, the delay provided the opportunity to reevaluate budgeting for the project, and we decided that there was value in pursuing an SRF loan, which is what's going to support this project. After securing that final agreement for the loan, we moved to bid the project over the past few months. With a successful bid received, we are now moving to approve the construction contract. I'm excited to move into this phase. This slide provides general overview of the completed and planned remaining schedule for this project. I do highlight the construction portion, that 2-year window. Half of that will be procurement of equipment, so we won't be seeing folks out on site until that second year. Next slide. And for this project, we have estimated a total cost of $9.3 million. The entirety of these costs will be covered by the SRF loan. The interest rates on these loans are extremely low. The rate for this particular loan is 1.75%. The state and the city have finalized the funding agreement, and that allows us to move into construction. Again, for more clarity, the original funding agreement estimate for this project was just over $7.4 million. As mentioned earlier, the bid proposal received was a significant increase over the most recent engineer's estimate guiding our budgeting. So this increase is the primary reason that we need to amend the agreement. To this point, we have experienced increases in hourly rates for design professionals, along with additional scope items for unforeseen circumstances, but those have been minor and compared to the overall cost of the project. So the primary reason for this increase is the construction cost. That being said, we have been preparing for the possibility of exceeding that original estimate. We've stayed in close contact with our counterparts at the state and are very confident that this amendment will go through seamlessly. Next slide. Quick summary. The final design included requirements for permitting, building review, and constructability. Floodproofing was added as an enhanced protection measure. We have a clear focus on safety and minimizing impacts, and all of that supported through effective outreach. I'd also like to note we have ongoing coordination efforts with other projects. This might be important for you. Other projects that will be happening in the area, including pedestrian and bike improvements at that intersection, along with a water main project up Cliff Drive. We continue to move forward with a focus on collaboration, and so we plan to ensure all work is organized and impacts are mitigated as much as possible. Next slide. Finally, the SRF funding agreement is approved January 31st. The project has been publicly bid, and the responsive bidder was Cushman Contracting for just over $6.5 million. At this time, we're requesting Water Commission support to proceed with the contract for construction for council approval.
Okay.
With that, any other questions?
Any questions? Okay.
Mr. Chair,
Yes.
just one, just for the record. We only had one bid. Just for the record, in terms of any comments on the fact that we only got one bid, why that might have been, and then with respect to city procurement policies, justifying that this was a legitimate increase in the estimated amount.
Absolutely. Chair Young, Commissioner Davis, it's a great question. We actually did have 6 contractors attend our pre-bid meeting, so there were 6 viable candidates. Of those, we believe at least 3 had significant interest. So there was competition in the bidding process. We reached out to those other possible bidders, and they actually had other opportunities at the same time, and it just turned out, they didn't put a bid in ultimately. But we feel that the prices are competitive. We actually had some contingency thoughts that the price could have gone higher, actually. And so the fact that we got something in that was at least beyond the worst case scenario and was in a competitive environment is why we want to continue moving forward with it.
Great, thank you, good job.
I just want to add to that. It is a bidder's environment right now. And this is happening not only to us, but a lot of different agencies. We've been looking into this quite a bit, and a lot of them have gotten no bids. And we're lucky we get one bid. We are looking at this closely and doing our homework, especially as the electrical project is scheduled to go out in May. We are contacting and have regular discussions with a lot of these contractors and trying to remove a lot of the red tape so we do garner that interest. But right now, a lot of those contractors have the pick of the litter, and it is a bidder's market right now. A lot of work is out there.
Okay, so we need a motion to approve staff's recommendation.
I move the staff recommendation to.
Okay,
Second?
all right, Madam Clerk?
Commissioner Davis?
Yes.
Commissioner Keller?
Yes.
Commissioner Snyder?
Yes.
Vice Chair Cooney?
Yes.
And Chair Young.
Yes. Okay, nice presentation, Mr. Molinaldo. Thank you very much. Okay, our last item, the most important one, always.
Thank you for saying
How
that.
much water do we have?
Well, I mean, exciting news still. This is good. So I'll set the stage. This is a stage that without January 7th to the 9th storm, this would be a pretty dismal winter. We'll give you the full end, but just keeping that in mind, we haven't really seen much after that single event to really change things. Yeah, so glad we got what we got. Let's just say that. So water conservation, as you might gather, for January was quite good. It was 29% below 2013, and for those keeping track of our new baseline of 2020, it was 9% below 2020. So yes, the community is continuing to do a fantastic job, as they should. Not be running their irrigation at this time. Should be good. There has been no official spill from Kachuma.
Good.
So what happened? What was all that water that went like that?
Just a figment of our imagination. It really wasn't water. No. That was a operational testing of the gates. The water that they used, we're not sure what water they used for that testing, but it was not an official spill. So you will note that we continue to track having 17,000 acre-feet of water in Kachuma in the city's name. And we've also put in a request for this year's allocation, which would be about another 8,000 acre-feet. So, let's see. In our graphs, I'm going to scroll down through these, and I'm happy to stop and talk about any specific one. This graph here, I would like to retire this graph. I feel like it's kind of served its purpose, and I think it has a role to play when things start to fall off again. But I think we're, seeing it kind of run its course. So don't anticipate seeing this again, but I did want to point out we've got the spill level and the lakes are certainly jumped up significantly due to one storm event, which is pretty impressive. So yeah. And then the other one I wanted to highlight was El Estero. You can see we treated a lot of water in, we treated a lot of storm water in January. And again, that's an average, and our average is typically 5.8, but we saw quite a bit. And again, this is really that one storm event, just kind of putting in perspective how much it moved our average for the month. Spills, this is for the fiscal year. As of the end of December, we were at 6. As a result of that storm event, we did have 4 spills. So we are at around 10 right now is my calculation on that. Just a quick update on our disaster responses. We did get the cable removed from the gates so that Gibraltar gates can close. And we've got some temporary repairs to the log booms. And we have a contract underway with Cushman Contracting to repair, so you can do some significant repairs on the remainder of our log booms. So we're working on that right now. There's an interesting time clock that's ticking. You have 60 days after an event to make repairs, and those repairs are covered 100% by FEMA. We did get approved for those costs, and so we're moving quickly. And then after 60 days, they become mitigation type repairs, and they're covered at 75%. So engineering right now is doing an enormous amount of work. We see Kelly back there, one of our new engineers. So our first day was January 9th. And we were glad that she was not unencumbered with any projects, so she could dive right into all of our disaster works. So really appreciate it. She's been working on that along with, you may have saw that we had a spill that we discovered 15 days after the storm event. It was on Mason Bridge. Our sewer main underneath that bridge got damaged on January 9th, and it wasn't apparent until we were able to safely get under the bridge and found it was leaking. It was a very small leak, but over 15 days it adds up. So we're looking to make repairs to that and harden that, so hopefully it won't be as susceptible in the future.
And have we completed inspections of all of our, bridges and overpasses where we have our creeks that flow through?
We have, and it was challenging with that one because you can't safely get down. Some of them, it's easier to see. We couldn't safely get down there until flows had kind of diminished, and that's when we came across that one.
But we're at that point now where the flows are.
Yes,
going
and
up.
we've looked at.
Inspected everything?
Yeah.
Okay.
Yeah, I don't anticipate finding any more there. As for March, I was thinking we might be able to cancel it. We have two items that have popped up, and they're oddly very similar. One is the low-income assistance program. The state has been rolling out a program and providing seed money for a low-income assistance program. We are doing our due diligence to see exactly how it's going to perform and whether it's going to help our customers. If we deem it viable, we would like to bring that back, because one of the other initiatives we're working on is we stopped penalties associated with not paying your bills. And we want to reinitiate that because we're getting people kind of taking advantage of that. Some people really need that, and some people are just taking advantage of it. And we'd like to actually see if we can coincide reinstating the penalties along with this low-income assistance program. So we're going to see what we can do on that. But we want to make sure we bring that back to Water Commission and then get Finance Committee too and Council on board with that. Because at any time the state could take away their funding for that program, which would put it all on us, and we've got to be prepared to take on that. The other one that is on my horizon is a water affordability audit. It's really kind of interesting. This company has popped up and they are offering to, and we're working on the proposal to come in and take a look at the city's rates, how they compare to our citizens and our low-income folks, and what maybe make some recommendations on what we might do, especially headed into next year and meaning to juggle water rates again, what we can do to continue to protect our low-income users. I'm really particularly interested because I've been drilling this home. Most of our low-income folks aren't living in single-family, they're living in multifamily. They don't directly pay a water bill. How can we help them? And these folks believe that they can drill in and help get us some more information on that. So anyway, with that, I'm happy to address any questions or concerns.
Any questions? No questions. All right. Thank you very much.
Thank you.
Thank everybody for participating, and we are adjourned until March 16. So is that going to be definite, Joshua, that we come back on March 16, or is that?
Hopefully I will know around the first when we get together.
Okay.
I'll be able to answer.
Great. Thank you.